Thank you, Janique, and thank you to the Brain Tumor Foundation of Canada for the opportunity to present today. It was great to hear Callie's story of hope, and my presentation will discuss genomic and molecular markers in glioma, and specifically how we are incorporating these markers in clinical care and research involving patients with glioma. To start, here are my relevant disclosures. And one thing that I also did want to mention is that in the context of this presentation, we will discuss some molecular tests today that are not necessarily implemented at all centers. There are institutional, practitioner and provincial variability in protocols for testing. So it's never a bad idea to speak to your primary team about what molecular tests may apply to you. So briefly, what I was hoping to cover today are the following questions, as these often come up in clinic when we see patients with gliomas. So first off, what do we mean when we talk about molecular tests and which ones are relevant in glioma? And the next question we often get is, how does the testing change the treatment or treatment plan or approach to each patient's tumor? And does everyone need molecular testing? Understanding that depending on the institution, some may be more available or routinely done compared to other institutions, and who may benefit the most from molecular testing. But first, let's take a step back and talk about brain tumors in general. We think about brain tumors as primary brain tumors if they arise from structures in the brain, and as secondary brain tumors or brain metastases if they grow somewhere else in the body and metastasize to the brain. Primary brain tumors are overall rare compared to other cancers like lung or breast cancer, but there are still about 27 new cases of primary brain tumors that are being diagnosed in Canada every day. And of these, glioblastoma, which we also refer to as GBM, is the most common malignant primary brain tumor. And as many of you may be aware, the prognosis for glioblastoma is quite poor. So less than 10% of Canadian patients with GBM survive for more than 5 years. And while GBM is at one end of the spectrum, there are many other types of gliomas that have better outcomes. And there have been important milestones in the past 5 years that have changed our understanding and approach to classifying these tumors, and I will elaborate on that in a minute. So how have molecular markers evolved, and how did they become an integral part of clinical practice in gliomas? A diagnosis of a glioma is usually made based on imaging and ultimately a biopsy or resection. So we see, for example, an MRI, something that looks like a brain tumor, and typically a patient will then undergo surgery to confirm this. And surgeries can be challenging, and depending on the tumor location, especially if the tumor is found in an area of the brain that houses vital functions, a full resection is often not possible. The tissue then gets sent to the lab for review by a pathologist, and prior to 2016, the diagnosis was finalized based on histology and patterns of staining alone, meaning that pathologists would review the types of cells that were present and based on certain morphological patterns, classify the tumors within subgroups. So for example, certain types of cells look like astrocytomas and other types of cells look like oligodendrogliomas. And as you can imagine, this method could be quite challenging even for the most experienced pathologists, as it relies on making the right diagnosis based on a very small amount of tissue at times. So in 2016, the WHO classification of brain tumors issued a major revision, which incorporated the use of molecular information to provide a more comprehensive classification. The 2021 revision, although not formally out yet, has also moved to include more molecular information. And why this matters is that we now have a better way of coming to a more precise diagnosis. So for example, these molecular markers, which I'll talk about more in a minute, are present in all areas of a tumor and therefore can overcome some of the limitations of a small biopsy. And another example is that occasionally pathologists can have differing opinions based on the slides that they analyze using histology alone. And integration of these molecular markers takes away this variability as it gives a more objective analysis of the tumor. This information is also now used to convey prognosis, or how well we think patients are going to do, and potentially help identify mutations that may be treated with specific types of drugs. So to understand what we mean by molecular markers, which are often surrogates for genetic mutations, we need to understand how cancer cells divide. And I think for some patients, even understanding the term brain cancer can be difficult because there is different terminology that is used, such as low grade or high grade, malignant or benign. But at a very basic level, we understand that cancer cells are abnormal cells that no longer respond to established cell cycles that all normal cells go through. And this is caused typically by mutations in certain genes that act to regulate that cell cycle. So we refer to these as genetic mutations because they because at the level of the gene, they occur at the level of the gene. However, they are not genetic, quote unquote, as is broadly understood when we talk about inheritable or familial conditions. So typically these mutations are not passed down to children or acquired from parents. So only about 5% of gliomas are actually due to familial or inheritable predisposition syndrome, and the rest are just mutations that occur in an individual alone. So another important notation to keep in mind is this term of mutant versus wild type. So mutant is usually when there is a mutation in the gene, and when we refer to a certain gene as being wild type, it is the normal variant of the gene that is present. So how do we assess these alterations in brain tumor samples? There are several techniques, and many of these will continue to evolve with emerging technologies and the lowering costs of doing these types of tests. And terms that you will hear being mentioned are immunohistochemistry, or staining of slides, chromosomal analysis, next generation sequencing, and methylation profiling. And we'll not go into these in detail today, but I just want to mention that while some of these are used routinely, more advanced sequencing analysis or methylation profiling is not currently part of standard of care and is only available at certain centers in the context of research. These tests can be costly, and the prices depend on the types of tests that are being run and where they are being run. There are also commercially available testing. So you may have heard about Foundation 1 testing, and this is often, again, not covered by certain, depending on the types of insurance. So it can come at a cost, at a direct cost to patients. So how have we incorporated this new molecular classification in gliomas? So this is now the proposed grading for gliomas. And I have included this diagram from a recent publication by the European Association of Neuro-Oncology. So as you can see up here at the very top level, we're still relying on histology. So we're still looking at the tumor to see what types of cells are present. And then following that, the next important sort of separation point is understanding whether a tumor is IDH mutant or wild type. And we can do this either through staining of slides or through sequencing. And this has come out as a prominent biomarker because we know that IDH mutant tumors behave very differently than IDH wild type tumors. So the IDH is an enzyme that is involved in a cell cycle. And what it does is that the mutant IDH actually generates a compound that is thought to lead to tumor proliferation in gliomas. And so within IDH mutant tumors, the next important question is whether we are dealing with an oligodendroglioma or an astrocytoma. And this marker called 1p19q can tell us, in addition to the appearance of the cell, more definitively whether we are dealing with an oligodendroglioma, as seen here, or an astrocytomas. Within IDH wild-type tumors, In older adults, the majority of these IDH wild-type tumors will actually be glioblastomas. And another important marker in particular in glioblastoma is the MGMT promoter methylation status, which is a marker of how well we think patients will respond to standard of care therapy. In particular, how well the chemotherapy temozolomide or lomustine will be effective on the tumor. And I'll have a few slides on this coming up as well. So let's now focus on how molecular markers has influenced our understanding and approach to IDH mutant tumors in particular. So focusing on this particular part of the flow chart here. So this algorithm may look a bit busy, but it summarizes many of the discussions that we have in clinic when it comes to IDH mutant gliomas after surgery. So depending on the grade of the tumor and some other factors, we decide along with the patient on whether or not to proceed with therapy. So if patients are considered high risk, if they have a lot of tumor left over from the surgery, if they have, if they are older in age or have worse neurological status, we may decide to treat them upfront with a combination of radiation and chemotherapy. In patients who are low risk, we can often monitor them closely with serial scans. And this is usually where shared decision-making with the patient comes in, but there are still many questions that remain. So IDH mutant tumors are predominantly a tumor of young adults, and therefore a lot of survivors can carry side effects for many years. And that's why these questions are not always clear and really are taken up on a case-by-case basis. We know that these tumors can behave indolently and look different on MRI from more aggressive tumors, and they can grow slowly, so the right time to intervene can be unclear. They can also occur in difficult locations, and I think Kylie's story of hope really illustrates this challenge. So removing the whole tumor or even attempting surgery at times can be quite challenging, and radiation therapy, which we often use in combination with chemotherapy, has been shown to prolong survival, but we know that this potential benefit needs to be weighed against neurocognitive effects on the long term or quality of life concerns that may arise down the line. So is there another way or another approach to these tumors? And there has been great interest in specifically targeting the IDH mutation. As you can see here, again, this looks a little bit busy, but it just goes to show that the mutation of this mutation in IDH at several levels can cause what we call gliomagenesis or proliferation of gliomas. We can see that inhibition at different levels of this pathway with several drugs under investigations could represent promising therapies or promising strategies in terms of addressing this aberrant pathway. So one particular IDH inhibitor trial that is worth mentioning, as it is open in many centers in Canada, including in Ontario and BC, is the Indigo trial, which is a trial in which patients with an IDH mutation are enrolled in either treatment arm with an oral IDH inhibitor or a placebo. And typically patients need to have had surgery for their glioma with no additional treatment and need to be several months away from surgery. So essentially, in the low risk group that we would have been observing, we now have the chance of trying an IDH inhibitor with the hope of changing the course of the disease. So we're very excited that our patients have had the chance to participate in this potentially practice-changing clinical trial. So what would the benefits of targeted therapy be in comparison to a current standard of care, which, as I mentioned, is radiation and chemotherapy in patients who are higher risk? We know that from smaller studies of IDH inhibitors, that these drugs, which are oral therapies, are often very well tolerated and are only very rarely associated with significant side effects. So using the strategy of targeting this particular mutation, we could potentially replace or at least delay the need for upfront radiation therapy or chemotherapy and reduce side effects from these treatments, which is particularly relevant, as I mentioned, in young patients. We now also know that some patients who receive long courses of chemotherapy with temozolomide can acquire high burden of mutations and develop treatment-resistant tumors. So using a targeted agent may be a better strategy to prevent resistance down the line and prevent malignant transformation into a higher grade tumor. So we have covered the IDH mutant tumors, but what about the use of molecular markers in IDH wild type tumors? So generally speaking, the majority of these tumors would be glioblastoma. So the first important way that molecular information has helped change the way we care for GBM patients has to do in the actual redefinition of glioblastoma. As we were discussing, it is now important to recognize that IDH mutant and wild type tumors are biologically different. So if a grade 4 astrocytoma is IDH wild type, it can be called a GBM, but if it has an IDH mutation, we are no longer calling it a secondary or IDH mutant glioblastoma, but are now referring to these tumors as grade 4 IDH mutant astrocytomas. And this is important because we need to think about them differently in terms of the approach, therapeutically, but also in terms of clinical trial design. So in addition to this, IDH wild type tumors of lower grades, so grade 2 and grade 3 tumors, can now be redefined as molecular glioblastoma if they have other molecular alterations, such as an EGFR or in chromosome 7 or 10, or in another gene called the TERT promoter. So we now know, for example, that we need to be more aggressive in treating these tumors despite their lower grading. Remember, grading is just based on the appearance of the cells, so the additional molecular markers really do add a layer of information here that is important for clinical use. And these tumors would now also be able to qualify for any clinical trial that are enrolling glioblastoma patients. So another important way in which molecular information has shaped the way we treat glioblastoma is to help us understand which patients may benefit the most from the standard of care treatment. And this standard of care treatment for glioblastoma remains the Stupp protocol from a landmark trial that was published in 2005, combining radiation and chemotherapy with temozolomide during a radiation for on average 6 weeks for younger patients, followed by 6 cycles of what we call adjuvant temozolomide. However, we know that not all patients respond the same way to this standard treatment, and there may be factors other than age and extent of resection that could be playing a role. So one of these factors is the presence of a molecular marker. So the MGMT, which is a DNA repair enzyme, is the marker that we typically test in glioblastomas. And how it works is that it is a DNA repair enzyme that following chemotherapy would be able to repair the damage that's conferred by chemotherapy in this MGMT methylated tumors. So we know, again, that when the enzyme is methylated, it is defective. So MGMT methylated tumors typically have a better response to temozolomide and lomustine, which is another alkylating chemotherapy that we use in glioblastoma. And as we can see here, when we look at the survival curves from that same Stupp trial that I showed one slide earlier, that patients with methylated MGMT promoters here have a higher probability of overall survival when you look at this trend over time. And this is important because we are dealing, unfortunately, with a disease still in need for a cure, and where quality of life is extremely important as our patients have limited time. So putting patients through chemotherapy when we do not think it has a high chance of success needs to be weighed against side effects and patients need to be counseled about this in clinic. So as you see, the recommendations for management now takes into account the MGMT promoter status. And for example, here in older patients, if the MGMT promoter is non-methylated, we may choose, in fact, to omit chemotherapy when giving radiation therapy. And we may choose also not to pursue further chemotherapy after completion of radiation. In addition to this, patients now are often included in clinical trials or assigned to specific arms of clinical trials based on their MGMT status. So it is truly being incorporated in the clinical care of glioblastoma, both on the practical and the research front. So the last application of molecular sequencing in GBM that I want to talk about is targeted therapy, which is a topic we have already discussed when talking about IDH mutant gliomas. And again, this figure looks busy, but it essentially shows you several cellular pathways that can be altered, leading to the formation of glioblastoma. And we can see here in the white boxes a number of different drugs that are currently under investigations, looking at specifically targeting these mutations. There are currently hundreds of trials across the world trying to find effective targeted therapies for gliomas. And while we're still far away from a home run, there are certain specific inhibitors that have shown a bit more promise than others. So to show you what a responder to targeted therapy may look like, this was a young patient with a GBM with a mutation known as BRAF V600E. And this mutation is also found in melanoma, and there has been a lot of experience in melanoma using drugs that target this mutation. So this young patient was started here on a combination therapy that targets that mutant BRAF pathway. And as you can see here on her MRI, this bright white thing here is her tumor. And after a few months of initiating therapy, we can see that she has had a very good response and further response a few months later. And this was actually sustained for several months, which was quite an impressive response in her case. So should we then be looking for targetable mutations in all glioma patients? The NCCN guidelines, which are a US-based set of guidelines, do recommend that for all of CNS and CNS tumors and gliomas that we try to incorporate as best we can molecular and genetic characterization. However, sequencing panels are still not standard of care in Canada. It can cost up to several thousands depending on the mutations on the panel. So while some actionable mutations can be found, this is still not commonly found in the typical IDH wild type mutation, IDH wild type gliomas. And we know that in younger patients, running these panels may be of higher yield compared to older patients, for example. So the actual clinical benefit of these panels for every single GBM patient is still unclear. So as I mentioned, one patient population that could benefit more from molecular sequencing are young adult patients because of how biologically different pediatric type tumors in young adults may look. And we know, for example, that there are some mutation in young patients with low-grade gliomas that can be targeted with oral drug therapies. And these patients can therefore, in some cases, avoid repeat resections and radiation therapy if they can have a good response to these oral therapies. In addition to this, GBM young patients with GBM often carry other mutations like the BRAF V600E mutation, like I mentioned, or sometimes a mutation in a gene called FGFR. And some of these mutations, again, are targetable. And in general, these patients have a better prognosis. So testing young patients with high-grade gliomas for these mutations has become more important. In addition to this, in some types of pediatric high-grade gliomas, we know that finding certain other mutations, so such as the H3K27 or H3G34, may help further understanding of their prognosis. So unfortunately, these two types of tumors carry a worse prognosis, but may hold the promise again of targeted therapy options in the future. So outside of their biological differences, young adult patients are different and deserve specialized care for a number of reasons. And I think Kali's stories highlighted some of the unique challenges of being a young adult patient with a brain tumor. And I do want to spend some time today talking about this population specifically because I think this has been an understudied population with an urgent need for more advocacy and visibility, and something that resonates with the BTFC community's vision. So when we look at the data, we see that the cancer community has largely failed these young adults with brain tumors. So as a group, mortality rates across adolescent and young adult cancers has declined overall, but there is an increase in, this is actually increase in CNS tumors. And CNS tumors are the main cause of cancer-related morbidity in this population. We talk about the transitional population, which is this population that is typically diagnosed or treated when they are children and then need to transfer their care to adult centers when they turn 18. And that's a prime time where patients can be lost to follow-up. Sometimes they get referred into the community and there is no real expertise or understanding of their disease at the time of follow-up. And another problem is that young adult patients with pediatric tumors are often treated at adult centers and treated using adult regimens, which may not be best suited for them. There's also a need for multidisciplinary care in young adult patients, so including psychosocial support, neurocognitive assessment, discussions around fertility preservation. And these needs are often under-recognized or the resources are just not there to provide this type of care to young adult patients. And lastly, young adult patients are underrepresented in clinical trials for a number of reasons, including trial inclusion criteria, but also psychosocial challenges in this group. So in an effort to address these gaps, we started an initiative in Toronto to put together a forum to discuss challenging clinical cases for brain tumor patients aged 15 to 39. So we rely on expert panels and discuss these cases with each patient's consent. So Dr. Sunit Das at St. Michael's Hospital in Toronto, myself, Dr. Uri Tabori and Dr. Cynthia Hawkins at Sick Kids Hospital initially started these rounds with some sites in Toronto, but soon after we realized that this impact could be broadened as the need for these discussions was really present across the country. So our initiative really came out of the recognition that young adult tumors require specific expertise. And our first rounds in April of 2021 attracted many experts across all CNS oncology subspecialties, so neurosurgery, neuro-oncology, radiation oncology, and pathology. And now providers meet twice a month to discuss particularly challenging cases. We've regrouped now close to 15 partner sites and 40 providers and have been meeting bi-weekly again to discuss these cases. It has been an amazing platform for clinical discussions and to enhance multidisciplinary neuro-oncological care. And our sites now include, sites all the way from Halifax to Vancouver. So we're really happy with the progress of the rounds. And hopefully this will be with more support and opportunity to develop further initiatives from the research and clinical trial standpoint as well. And in addition to this, further illustrate that there is this growing movement to study and improve outcomes in young adult patients, I also wanted to highlight a few other projects that are happening in the adolescent and young adult glioma space, including this Toronto Young Adult Low-Grade Glioma study by Julie Bennett in Toronto, this large study by Dr. Sumit Gupta, also in Toronto, looking at outcomes for adolescent and young adult patients with brain tumors. And last but not least, and this is my personal plug to acknowledge the BTFC and its donors, our project to assess outcomes in young adult patients with brain tumors and to study how treatment and unique patient features can affect outcomes. So I look forward to sharing more of this work with you in the future. So in the last few minutes, let's summarize where we are in terms of molecular markers and what we should be looking forward to. So here's where I think we are in 2021. We have come a long way in understanding the classification of gliomas and the distinct biologies based on molecular testing. We are, however, still far from a home run when it comes to treatment, but many promising targets are being investigated. So the goal should really be that in 5 to 10 years, we're able to recommend specific and effective treatments for each and every glioma patient at each stage of their disease with the guidance of molecular biomarkers and other unique patient characteristics. So the challenges in getting us there are too many to list, but to summarize a few, these include delivery to the brain, which can be difficult due to the presence of the blood-brain barrier. We know that clinical trials take time, and because glioma is still considered a rare disease, funding and data is often limited. So how can we help move the field forward? So we are making some strides in all of these areas. For example, new methods of drug delivery are being investigated with really intriguing preliminary data in brain tumors. So prime example of this is the focused ultrasound guided treatment, and soon to be hopefully translated into focused ultrasound guided targeted therapies. So part of this work has been spearheaded and is being led by Dr. Neil Lipsman at Sunnybrook. And we have now several clinical trials that are looking at using focused ultrasound to open up the blood-brain barrier and administer chemotherapy. So this is being looked at right now in newly diagnosed and recurrent glioblastoma, as well as CNS metastases. So hopefully a lot more to come on that front in the coming years. We are also refining clinical trials to improve efficiency. So as I mentioned, the challenge is that glioma is still a rare disease and trials can take a long time. An example of how we're improving this is the GBM AGILE trial, which is a trial where several arms are exploring different therapies compared to a control arm, and through interim shorter term analysis can adapt to randomized patients more effectively. So we expect that with this trial design, we'll be able to reach conclusions much faster and understand which experimental arms are performing better and for which types of patients. This trial is now open at Sunnybrook, Princess Margaret, and also at Princess Margaret in Toronto, and at the Montreal Neurological Institute, both for patients with newly diagnosed and recurrent glioblastoma. And lastly, there is a need to improve and encourage research outside of clinical trials. And this is not mutually exclusive. So patients who are in clinical trials can still be part of other research studies. Prospective and well-annotated databases, so where we collect information about patients' tumor types and outcomes, can provide helpful information in rare diseases such as gliomas. And this is why at Sunnybrook, we have also launched a prospective database where all gliomas will be sequenced and patient outcomes and imaging variables will be captured to better help us understand molecular predictors and imaging predictors in glioma. And in addition to this, non-invasive biomarkers are being looked into. That is, we are now looking into finding these molecular signatures in blood or spinal fluid, such that in the future, we hope to be able to use these to help us understand the changes in patients' tumors over time. And lastly, I would just like to drive home that every patient can make a difference, as collection of this data over time will really help us understand the evolution and unique predictors of response and resistance to therapy. So in summary, I hope that I was able to convey to you today that molecular classification has reshaped our understanding in glioma and has expanded research into a really exciting time where we are looking at targeted therapies and predictive biomarkers to help with precision medicine. And the other important point is that young adult CNS patients have unique needs based on distinct tumor biology. And my hope is that we will be able to continue building on the recent projects in young adult care in the city and across Canada to truly create a pan-Canadian multidisciplinary program. And lastly, precision and collaborative care in CNS oncology is here. Patients have a major role to play specifically in research and advocacy for better access to molecular testing. And the time to do this is now. So in conclusion, I would like to thank my team, the CNS oncology team at the Odette Cancer Center. Their work has been highlighted many times during this presentation and through other initiatives from the BTFC. I would also like to acknowledge collaborators across the University of Toronto, but also across Ontario and Canada. And lastly, I would like to thank the SLAM and FAST initiatives in neurology and also the Brain Tumor Foundation of Canada, who have helped fund some of the research that was discussed during this presentation. So I'll now take any questions that you may have.